So I'm just going to jump right in. Hi, everyone. My name is David Staggs. I'm the CTO for Jericho Systems Corporation. We specialize in policy decisioning software and data segmentation software and protecting healthcare information. So you may have seen me last year, the year before. I'm very passionate about being able to take the step of exchanging healthcare information because I know how critical it is to Deborah, critical it is to, critical it is, how critical it is to providing good health care. It's vitally important, but as we begin to, maybe I was just naive when I got involved with the exchange of healthcare information, but as we start to exchange these patient records, you get the incredible advantage of being able to, have access to your record when you break your leg in another state or something like that. So of course it all makes sense. But now we're seeing the collection of a large amount of data, and we're seeing businesses seeing that as an advantage, some kind of gold mine, and they're able to perhaps make a business case for using data. And it may be good for people, it may not, we don't know. But there's a lot of questions about that. So one of the issues we want to cover is where the health data is. Just kind of a threshold question, do you know where your healthcare data is? So we've assembled a group of great panelists, and they all have different perspectives, and they have great deep backgrounds about implementing HIEs and making data available and being able to use it for different purposes. So I'd just like to open it up, and I'm going to ask each panelist to introduce themselves. Then we'll do a kind of a question and answer approach. We thought about everyone providing their own PowerPoints, but we're going to try to make this interactive. So I'll start us off with a couple questions, then we'll have plenty of time for the audience. You want to start?
Sure. Hi, good afternoon. Thanks for having me here. I'm Linda Rowe from Booz and Hamilton. I actually started in this field many years ago, but I worked with the Massey Health Collaborative in Massachusetts. They started up some pilots on health information exchange long before high tech even hit, and we grapple with a lot of privacy and security issues. At Booz and Hamilton, I've been focusing on supporting federal clients through health information exchange, such as the Beacon Communities. I actually had the opportunity to spend my last year in an organization that we started up within Booz and Hamilton called the Strategic Innovation Group, and that group was really looking at innovative and new and different ways to use technology to help our clients solve problems. And one of those problems is, how do you start to use healthcare data, all kinds of healthcare data, and I'm not just talking about payer provider, we're also looking in the research space and public health, to really start accelerating and solving those problems. So with that comes the challenges of looking at big data and privacy, and how do you aggregate that data, how do you match that data, and then how do you come up with some interesting analytics that will help our clients solve those problems.
I'm Sean Grannis. I'm a patient, I'm a physician, I'm a family physician, and I'm a medical informatics research scientist at the Regan Streif Institute for Healthcare and Indiana University School of Medicine. Regan Streif has developed information technology and medical information technology for about the last 40 years. We operate the country's largest and longest running information exchange with over 14 million patients, over 6 billion discrete coded results in our system. We have published more than 40% of all of the peer-reviewed literature on how information technology can support physician decision support at the point of care. This information exchange also is used to support hundreds of clinical research projects, and the architecture that we've used in Indiana has also been deployed in the country of Rwanda, and we're also working with other countries like the Philippines and Bangladesh, as well as other countries begin to think about how to mobilize clinical data. So looking forward to the conversation.
Well, good afternoon. I'm Ann Jaeger. I'm Executive Director and CEO of HealthyWay. HealthyWay is the support organization that supports the eHealth Exchange. It's actually stemmed from one of ONC's longest standing initiatives related to the nationwide health information network. We took over responsibility for supporting this endeavor in October of 2012, and today it is a rapidly growing, completely federated network of exchange partners. So Indiana Health Information Exchange, formerly connected through Regenstrief, is one of 51 organizations who participate in the eHealth Exchange community. They are all bound to comply with a common set of requirements, including, notwithstanding, privacy and security. And there's an accountability mechanism and oversight structure through a committee. What's most, I think, important is the rapid uptake of HIE, and I thought that how timely this panel discussion to talk about the future of HIE, because it really is not experimental anymore. I mean, you had the early adopters, like the folks at Regenstrief, but today it's quite commonplace and widespread. Within the next several months, the number of participants in the eHealth Exchange will reach 100, which actually will connect more than 1/3 of the country's hospitals and information regarding 100 million patients. So you can imagine that privacy and security has always been on the forefront of everything really since inception, and it's certainly something we pay close attention to. So thank you very much.
Good afternoon, everybody. My name is Damon Davis. I serve as the Director of the Health Data Initiative at the Department of Health and Human Services. I'm in the Chief Technology Officer's office, where predominantly our work is represented by healthdata.gov. It's a catalog of the department's health data resources from across all of our various operating divisions in an attempt to return data to the innovative community, the research community, educators, et cetera, so that they can find some secondary uses for the data that's been collected and curated out of the department's various programs. So we've got a strategic and execution plan online for how we're trying to make data more openly available through our various activities across all of those operating divisions. And so, needless to say, the privacy of individualized data as it relates to the government collection data is one of our many concerns in the data space.
What'd I tell you? See? So we have this great panel, a variety of experiences. So I'll just start off with some questions. And Marianne was mentioning that we're coming up on 100 million patients, data accessible. Let's ask Linda about that. As you see the volume of HIE and the amount of health information being shared, do you have any ideas about, will this be shared in the cloud or in a data lake, or what's your perspective on that?
So I think it's interesting because we're probably at a tipping point where our existing technologies and infrastructures can probably still use and support the current data sets, but we're starting to bring online a lot more data. Variety and velocity are the things that we look at when we think about when do you start thinking about a big data solution. And so as we start thinking about bringing in genomics and some of the biosurveillance data and embedding within that the patient data as well as some of the big claims data sets, that you have to start thinking about different technologies. And the way to do that is to start thinking about putting that into, we think of private and public cloud. So we're looking at private cloud solutions through Amazon, which gives us the ability to take those data sets and actually run analytics on it in a way that you just couldn't do traditionally. And so that's one of the benefits. I mean, if you think about why we're trying to do what we do, it's to try to improve care. And you do that through information, you do that through analytics, you do that through prediction. And so as we scale up our data sets, we're going to need a way to be able to mine that data and run things faster, and also not only look at the data and sort of ask it questions, but sometimes what our data scientists see is that the data itself starts to inform the questions they should be asking.
One question people might be thinking now is exactly where is the cloud physically?
So it resides, so our data center, we've got a data center, but we also work with Amazon, and Amazon has they have data centers where they have private instances that just have our data. So they're it's like any other data center, right? It's just, it belongs to us. They have a number of different nodes or processors that exist out in the cloud. And what we have is a set of technologies that actually allow us to sort of bring online processing power as we need it. So it's spanned across multiple sort of servers, multiple locations, but it's still physical devices, right? It's just, it's not in our, it's sort of in your backyard, the way a lot of us grew up with, the mainframe was down in the basement of the hospital. So it's sort of the same concept. It's just you're accessing it through, the internet and other technologies.
So you mentioned you have your own private cloud, or some of the sometimes you have your own private cloud. Are there any implications for privacy as far as cloud technology?
So again, I think there are a couple pieces, right, to protecting data. So the first is sort of the basic infrastructure, and do you trust your provider, and are they abiding by HIPAA, and are there secure data centers, right? And so we're working with Amazon, and clearly they're going to be as secure as any other large data center. What we're finding, though, is that there's some interesting technologies that we're working with that are bringing security and privacy aspects into the technology. We use a technology called Accumulo that actually allows us to look at cell-level privacy and security, or cell-level protection of our data. So when we go and query a data set, we can actually, instead of pulling a row-level sort of locking of the data, in other words, when you're querying the data, often when you look at a database technology, you can only sort of lock it down to a certain level. You can actually say this cell is secure and only one person can look at the data in this cell. And so you can get to that level of granularity, which again is something that we previously weren't able to do with some of the more traditional technologies. And this was really important for us as we started to talk to our federal clients about using this kind of technology with them, because they're really concerned about the privacy aspects of the big data and using the technology. So that's one of the things we actually have to talk them through and convince them of. We've gone through FISMA compliance. So we take this very seriously in terms of who our clients are and how they think about what we do with the data.
Well, you've talked a little bit about analyzing, doing predictive work, and part of that we can call syndromic work or syndromic surveillance. Sean, you have some experience in that, don't you? Can you tell us what that means?
Sure. So syndromic surveillance, or surveillance in general, that's a conflation of a lot of different terms. Surveillance is, generally speaking, the collection of data to either analyze or implement or evaluate systems. We, in Indiana, for instance, have a statewide surveillance system that monitors for any unusual disease trends. We have detected, for instance, a case where a number of patients came to an emergency department complaining of dizziness, nausea, fatigue. In fact, patients were coming to 3 different emergency departments. And in fact, no physician realized this trend. And in fact, there was a carbon monoxide outbreak at a apartment complex. This would have gone undetected were it not for the surveillance system. And so one of the points I think it's very important to think about as we think about surveillance or a use of a system and the value it brings. These are very complicated questions. Should we be monitoring, in terms of the privacy trade-off in surveillance, we need to define our terms very carefully. Privacy in its simplest concept is a state of being free from public attention. But I would contend, if we ask every person in this room, what are your expectations for privacy, I will get n squared different answers. And being the total number of people in here. So answering the question and understanding how does a particular use of medical data impact privacy is a deceptively complex question. And I think it comes down to expectations of privacy and expectations of value for that process. We have found clinical outcomes in our systems that no clinician would have observed. We found a patient who over the course of 3 years in our surveillance system was seen over 300 times, 385 times in the course of 3 years. Data tells a beautiful story sometimes. There were 2 diagnoses for this person that made perfect sense why they were seen 385 times. The first diagnosis was sickle cell anemia. This person was in sickle crisis, lots of pain, their joints hurt. They came in for pain medication. Okay, but 385 times in 3 years? The second diagnosis seals the deal. This person had schizophrenia. And so here was a person with a chronic disease, unable to manage it, who was going around to many different emergency departments. And again, the care system did not detect it. The surveillance system did. This person needed to get into a medical home. And again, this is the example of what we can do with surveillance. Similarly, in the country of Rwanda, Rwanda has one of the highest maternal child death rates in the world. Rwanda has 3 components to its maternal child care. Number one, they have community health workers who walk the streets in every city in Rwanda looking for sick people, including pregnant women. Number two, they have clinics where pregnant women are supposed to be seen 4 times. And number 3, they have hospitals where complicated pregnant patients go to be seen. These 3 systems do not communicate. The sick patient in the community never gets to the clinic. The sick patient in the clinic never gets to the hospital. They have a very high rate. These systems didn't communicate. By building an integrated system and be able to monitor this, we can follow the decrease through our surveillance system, can track these patients and decrease death rates. So there's some examples of surveillance and how the systems can deliver value.
Great. Those are great stories. So one of the things I think about when talking about looking at data or surveilling is a question about who owns that data. Is that data that you can just go out and look at, or there's some ownership in the patient? Do you have to ask permission?
Yeah. So the data ownership, or I like to think of it as a stewardship question, I think it varies for every kind of health information exchange. If you've seen one health information exchange, you've seen one health information exchange. And there are different models and different varieties, but I think fundamental across all of them, we talk about data ownership. The reason why I like the term stewardship better than ownership is the following. Healthcare systems provide care, and they have to document or justify why they're billing for a particular case. So healthcare systems, providers need access to this data. Patients, of course, it's their data. They need access to it as well. And of course, payers also need access to this. So there's examples of at least 3 stakeholders who might be able to make the claim in a crude way. They own the data. So I think there's a stewardship question here that we need to be thinking about. While as a patient, I agree, it's my data. I certainly can recognize why the payers and the providers might say, well, we need access to this data as well. So we need to work together to figure that out. In an information exchange, let me give you an example of what we're doing in Indiana. In Indiana, the stakeholders in the exchange own the data. It's not the exchange's data, it's the stakeholders' data. And if tomorrow one of our stakeholders, one of our healthcare systems, one of our hospitals, one of our clinics says, we're done, we're out, we turn off their partition in the system, it goes away. So that's number one, the stakeholders in the HIE have control. Number 2, a lot of folks ask us, how can the patients access the HIE data? And the answer today is those patients go to the hospital systems, the healthcare systems who own the data. The HIE itself today does not directly provide data to patients. They go through their respective healthcare institution to do that. That's one model. I think we're in the early stages of developing mature data stewardship models given the multiple stakeholders involved in accessing patient data. So these are great topics, and this has been a great conference, and I just want to say I hope we got some good questions and good pushback because these are important issues. Mm-hmm.
Well, one more question. Sure. Where is the data in your experience?
Sure. So again, there are different models, but physically in the information exchange, the data lives in 2 places. It lives at the originating institution. I've got an 8-hour discussion of the architecture, but I'll try to. So the data, of course, lives at the original generating institution, but then that data is mirrored into the exchange in a federated repository where each organization controls that repository. Why did we do it that way? There is none, zero, zilch, nada, any information exchange that offers performant data queries that are peer-to-peer. Zero. People who think that you can do peer-to-peer information exchange, I will challenge you on that. And I'm doing that because I want to get some good discussion here. There is no large-scale operational information exchange that does peer-to-peer information sharing where all of the data resides at the originating institution only, for a variety of reasons that we can talk about. So in our information exchange, it's both centrally managed in a federated fashion and at the original institution.
That's interesting. Yeah. I had thought that the VA, for example, was an example of keeping all the information until it's requested. Your example seems to be you prefetch it, you get all the information locally, and then when it's requested, it crosses boundaries.
Yeah. So, it's, just a quick response to that.
Right.
Part of the reason we federate is we offer completely standardized. So a patient with diabetes for 20 years, their hemoglobin A1C captured by a system has changed 60 times. The vocabulary changes over time. If you want to watch longitudinally what happens to a patient, you need to standardize that data. The VA system, every VA instance modifies their vocabulary over time. So the Utah VA, the Indianapolis VA, they all have different data elements in their system. So if you truly want to do integrated population health tracking, if you want to watch the bilirubin of a patient over time in the VA, you actually, what physicians are doing is they're taking, it's like a paper-based system. You take a document here, you put it together because you can't electronically view them over time.
Okay.
So, yeah.
Thank you.
Yep.
So you talked a little bit about the federated model and the speed that when groups are exchanging over a federated model. I think Healthy Way is a federated model. Is that right, Marianne?
Well, HealthyWay is more like the management company
Okay.
that supports the eHealth Exchange. So the eHealth Exchange is, it's correct, it's federated in that no data goes through a central point at a national level. And that's important because there are aggregators, just like Sean was saying, who are at the edge who are aggregating the data and then interconnect with each other.
Okay. So are those like data brokers? or are data brokers actually participating in that sort of request?
So, that's a great question because we are seeing this space evolve dramatically in a surprising way that was never originally anticipated. So to date, the lion's share of participants in the eHealth Exchange are HIOs, whether they're state or regional, health systems on an increasing basis, or federal agencies. That composition is shifting pretty dramatically to be a higher percentage of health systems are joining as their own HIE nodes. What we're starting to see, however, are a new flavor of intermediaries coming forward, and they want to now join this trust community. So we've been very conservative from the very beginning in defining a set of policies and expectations and a governance process and technical architecture that enforces policy and allows policies to be applied in an automated fashion, and that's worked pretty well. And so when there are probably 3 different types of organizations that have come forward recently, and we've actually mentioned this to ONC in a number of forums, that there does need to be some very thoughtful policy work here. One is we're seeing release of information companies. These are companies who are contracted by healthcare provider organizations, and they actually manage the release of medical records. So typically, if a health system or hospital or provider organization receives a request for records from an attorney through court order or whatever, they outsource it to these release of information companies, and they themselves are doing these types of managing these releases in an automated form. They would like to join the eHealth Exchange and serve in a similar fashion to respond to requests from the Social Security Administration to release records under the authorization of a patient. So they also maybe one day, now that they're an intermediary, might want to request data. And that, you can imagine, a whole flurry of questions are raised by that. So there's no decision that's been made to do that, but it's being studied to assess the implications. The second flavor of an intermediary we're seeing are EHR vendor networks. Now, I will say this because I think this is a sympathetic audience that nobody trusts a vendor to be the recipient of health data. And the questions there are a whole host of questions that are being evaluated, and there's been no decision to allow these types of vendor intermediaries to join. But the question is, if they're just releasing record on behalf of their provider customer, that's one thing, but if they have the right to query it, are they doing that on behalf of the provider? Are they doing that on their own behalf? What do they do with the data once it's received? Because the policy was written in a way, once the data are received in the ultimate system of record, basically applicable law and HIPAA and other things govern the reuse of that data. And so the other question is one of transparency. Are the healthcare providers aware that their vendor may have access to this data and exchange it for these purposes on their behalf? Who's accountable? Is the vendor accountable? Or are they going to try to pass all the liability on to the healthcare provider customers? So, I mean, literally, we see that there is all of those questions and issues said that they need to be thought through and worked through in a very thoughtful way to preserve the trust that we've worked so hard to build. But on the other hand, we have to recognize that the vendors play a very important role in enabling the exchange of ambulatory providers and certainly others who are not as sophisticated, like the post-acute care settings. So we've done a fabulous job of connecting hospitals, but we've done a horrible job connecting physicians. And we haven't done enough to connect, post-acute care settings. So if we're really going to get to really better coordinated care, we've got to work it out, and that means recognizing the role of these data brokers and being very thoughtful about the parameters under which it may be appropriate for them to be a party to the exchange. We haven't figured it out, by the way, but that's what we're saying.
Well, I agree that I think of I know Linda was involved in the ONC Beacon communities, and I know the Nationwide Health Information Network has been basically the backbone for the country. So Healthy Way has an incredible reputation, and so when you talk about where the data is, can you explain a little bit? Is it kept at the providers, or do you keep data nationally?
No data is ever transmitted to Healthy Way.
Okay.
In fact, it's prohibited by policy, even for testing purposes. It's prohibited for us to touch the data, and we don't ever have a need to. For testing purposes, it's all fake data. So the data resides either in the healthcare provider organization or an HIO, like in Sean's case, it would be housed there. The only thing that Healthy Way maintains are digital certificates, which are used by the partners to authenticate to each other so they know somebody's trusted. We maintain a registry of endpoints, but no PHI, no medical records, and nor do we have any plans to do so.
Thank you. Okay, so that's how the data is exchanged, and there's nothing at rest, a Healthy Way, but there is something called healthdata.gov that
Yes, there is.
involved in. Can you explain that?
Sure. So I probably should start with an answer to the last question that you asked, Mary Ann, which is where does the data live? So healthdata.gov is a representative catalog of the data assets from across the department. So it is not a repository itself. You cannot go there and actually dip into the data as much as you can get redirected to the operating division. And when I say operating division, I'm talking about National Institutes of Health, FDA, CDC, CMS, and so many others, where they are actually the holder and curator of the data in their own repository, responding to their own requirements for the data's security and its various states of being. So there are multiple different ways that you can get to some of the data, some of which is available through research activities. So you actually have to apply in order to get any level of access to the data. There are others that are just simply freely available because they have gone through processes of de-identification in multiple different levels, such that it can be made available for some level of alternative use. So keep in mind that healthdata.gov is set up with the idea that you may have done some grant research, or you may have done some other level of activity, be it contract or otherwise, that has produced some data. The goal then is to see if there is an alternative use for the data that may create a new innovation in the healthcare space. I think we all probably are familiar with how vast healthcare is, and it's a almost $3.3 trillion industry. The idea that we have fraud, waste, and abuse, and all kinds of inefficiencies where data can drive new innovations that can help us to find solutions for those. We want to make that data freely available as much as possible so that you all can innovate on it in the different ways that you see fit. So healthdata.gov does not hold data itself. The data resides in the repositories of each of our operating divisions.
And is there any implications for privacy in that, or what do you see as?
Yeah, I mean, absolutely. The federal government maintains data on people in many different facets. And in the healthcare space, as I've said, there's research. There are all kinds of grants where, social services are provided in the communities. There is, a perfect example of where privacy might be really strongly considered is out of our Indian Health Service. You can imagine that that's a very, very finite population where as soon as you release any level of data about any Native American population, you could probably quickly begin to re-identify where that person or that group resides in the country. So there are some significant barriers to releasing certain kinds of data with considerations of privacy along those lines. Another example might be the Human Health Resources and Services Administration, or HRSA, has grants and activities that support folks who are in what's called the Ryan White program, where if you do not have the means to receive AIDS treatment because of economic or other factors, they can help to bridge the gap so that you can receive AIDS treatments in certain communities. You will never get Ryan White data out of HHS. So those are just a couple of little examples where privacy is very, very strongly considered.
So do you ever ask the patients that generate the data, do you ever go back and ask them for consent or?
That's a really good question. One of the interesting things about my position is I'm in the Chief Technology Officer's office. So I'm at sort of a higher level from where the data is actually collected and curated. So I don't actually know the answer to that. I would actually love to go back and find out what the answer to that really is. But I mean, that's a broad question because, again, it's an agency of 90,000 people with, we're the largest grant maker in the nation in terms of the federal government. It would be really challenging to get sort of one answer to that based on the number of activities that we are engaged in on a regular basis.
Well, I'm going to open up the mics in a second, so get ready. But just to finish off, I want to maybe go back in reverse. Damon, maybe you can start. Do you think the ability to keep control over access to our electronic health information is adequate right now? Kind of following on to that, do you get consent?
Yeah.
And do you think it's going to be changing in the next 5 years?
Yeah, I think we're in a time of maturation right now with all levels of health data usage. And so specifically from the federal perspective, I think we have to not necessarily think of privacy as an actual finish line, but a continually moving goal, because there will always be new requirements or new requests for different levels of data. And I don't think that we'll ever be sort of finished. So I think this is an evolving thing that we need to be continually engaged in, and it's a set of activities that we're going to have to constantly acknowledge the evolution of in order to sort of at least keep up to date with, if not try in our best attempts to stay ahead of, in consideration of new types of data that we're collecting, new requests for data, as was said by Mary Ann about intermediaries who are now thinking of their new position with their access to data. So it's going to be a continually evolving landscape, I think.
Thank you. Okay. And Mary Ann, do you have a response to that about whether our health data is adequately controlled, and do you see that changing in the next 5 years?
Well, from a Healthy Way position, those are all local decisions in terms of access. I have a different personal answer. I think more could be done, to be honest. Let's face it. We need better capabilities to have better access control. There's no question. But I think that really holds such promise for what we can do, and we're starting to see these more innovative approaches, more technological approaches. And one good example is actually a project that we've been trying to really spin up and do in conjunction with ONC, and that is to have a consumable consent. To take consent and create a national standard so it's consumable by systems. That would be fabulous. We think we could do so much more around consent management, and there are lots of different approaches out there, and they're all very interesting. But I think that's one.
Oh, that's a great
Yeah,
program to get involved with.
We're scoping it. Yeah.
Yeah. And do you have? comment?
Sure. I think it's kind of a softball question. Of course we can do better. There's no question about that. We can always do better. Well, so I don't think there's a person in the room who doesn't believe that we want to secure and manage healthcare data in a way that patients expect it to be done. So there's a vision, okay? And there's where we are today. Where we are today with the kind of data that we have, we are limited in what we can do to achieve that vision. So we were funded by ONC. It was a cute project called Aspiring to Awesome. I don't know who named the project, but we were funded by ONC to look at, given the kind of data that we had, how do you develop privacy controls? And so we looked at a number of different ways of granularly restricting data access in the information exchange. Fundamentally, what we found is you can restrict on what provider received the data. You can restrict on a time period when you receive that data. You can restrict on, so a provider, facility. You can try to restrict on concept. But here's the thing, and it was mentioned in the last session. We deal with a lot of free text data, and we deal with a lot of metadata. So if somebody says in a hospital discharge summary the CD4 count was 22, what do I know about that patient? They have HIV. If no HIV wasn't mentioned, but I now know they have HIV. So that's number one. Number two, if I go to the Betty Ford clinic, what does that tell you? Okay, so there's all sorts of inferences that can be made on top of whatever filters we think. So we need to, there was a statement earlier that I really like, do we educate or legislate? And so we either need to legislate that Betty Ford Clinic data never ever goes anywhere, or we need to educate patients that there are implications for sharing their data. And these are the complicated nuances of these privacy issues we've got to think about. There's nobody here who doesn't believe that we need to protect patient data, but we have to deal with reality, right? And what I'm suggesting is we start today. If a venture capitalist was to give me money today to protect patient data, I would restrict on patients, facilities, and as many clinical variables as possible. But given the free text and metadata out there, it's a losing proposition, and I think I just offended a lot of people.
Well, that's good. We can take their questions. I wondered if purpose of use would get in there, and I wondered a few other things, but I think that's a great start. And Linda, do you have a quick comment?
So, I want to dovetail on something you said about, when you ask people what they think about their health data and whether it's being protected, and you can get multiple answers. That's absolutely true, and that makes it even harder. It is a context issue. Certainly there are people that share things about themselves very publicly, believe it or not, through Facebook or Twitter or whatever. You tell your friend, oh, I'm feeling really sick. Well, guess what? You could actually pick up Twitter feed data. So, it's sort of how you share your information is very context specific, but then who can get access to it is a whole other question in terms of the context in which you share it. And clearly, as we look at these big data sets, that's a question we have to ask. I mean, at this point in time, a lot of the work that we're doing is very specific to clients, and it's very, and in many cases, it's de-identified because we're still trying to answer those macro questions as opposed to the patient-specific questions, because we haven't drilled down to the patient level yet. But we'll get there, and then when we do that, the question is, well, does the patient information live in a different place than the aggregated data set? And then you only pull the specific data for the patient when you really need it to answer that specific question.
Thank you. Okay. So we're going to have some questions from the audience about, do you know where your health data is? So this line's longer. Let's try to start there.
I'm going to ask, do you know where your data is in the following specific sense? The you and the you are in there is the patient. We've had accounting for disclosures as part of the foundation for everything that's gone on around data sharing before and after the neutralization of consent in HIPAA. And my question to you is, how can you build your various health information exchange solutions on such an incredibly shaky foundation where I, or if I'm the proxy for my mother's health care, cannot cannot conveniently know when she's seen a particular doctor, when that information was shared, when it was used for research maybe, if that is what, so it seems to me like you're putting the cart miles before the horse by not building on accounting for disclosures in real time as the foundation, rather than pushing it another 10 years into the future.
I'll take a quick. So
Yeah, I have a question.
I heard you say, why do you think it's a shaky ground, and why do you think we're not accounting for disclosures today?
Yeah.
From a security standpoint, when I deal with Google, when I deal with Apple, when I deal with my bank, I know that when there's sensitive information involved, I can count on getting a text message, I can count on getting an email, sometimes even a phone call, and I welcome those calls. If anybody tried to do that 10 times a day, I might either change providers or opt out. Don't, check the box, I don't want to see this message again, but it is fundamental to
So
security
you're suggesting
practice.
more transparency, that you be contacted?
Do you know where your health data is?
Yeah,
I'm
yeah,
suggesting it
where-
as a
it's after midnight.
foundation.
Yeah, right.
So
Okay.
if I could just jump in on that, I think it's important for us to recognize where we are in the maturation of our health information exchange versus some of those other places that you've mentioned. In the financial services world, they've been using IT in a very robust manner for decades before now, where I feel like health innovation is really moving all of our records and things into a place where they can be online, such that we are in this position where we now really, really strongly have to think of all of these various considerations for health information exchange, et cetera. So I understand your perspective, but I think we also have to maintain our perspective on where we are in terms of IT implementation across all of these things. I don't disagree. Yeah. I'm simply saying I think we need to consider it, and it has to be strongly considered in the appropriate manners, and we should learn lessons from some of those other IT implementations across various other industries and other domains. But I think we also have to be very considerate of where we even are in terms of the proliferation of data in electronic formats.
Well, I can't say I disagree either. I mean, I rather like being alerted from my financial institution when things change. There are a couple things now in the e-health exchange world. The use cases would not even be required to be recorded for accounting and disclosures because it's for treatment purposes and pursuant to an authorization, right? Am I wrong on that? No. No disclosure. Well, anyway, but in our world, the information that you would need to record an accounting of disclosures, it could be facilitated actually. What would have to happen is the data are transmitted back to the recipient of the data or the requester of the data so that they could record the accounting and trigger those alerts to the patient. So in our architecture, it's possible. It's not best practice, and I think there would have to be a lot more scoping of the capabilities. But I think you raise an important question. I mean, I think that we do have that in the financial services field. Mm-hmm. Why can't we have it for us?
Adrian, you might.
Right.
Re-identify the data if you know.
Adrian,
Well,
you might also know that the Jericho, UT, Texas, at Austin pilot with Conema Health Systems, we actually demonstrated that, where we built our own and we were able to use Aetna messages to go back and tell the patient whenever his information was requested. It's just a proof of concept, and you can find it on the S&I framework ONC site. Sean?
I appreciate what these folks have said. I think we will be getting there. So again, the reason I asked you, why do you think we're not, we actually log all accesses, and when patients want to, so patients do come to the HIE sometimes, we're just not permitted to respond to them. The stakeholders have to. We've got the information. We know who's been accessing the records. The question.
The patient doesn't know. Do you know where your health data is? It was the question.
Mm-hmm.
Okay, we got a bunch of other questions on the line. Do you want to take a quick response, or should I move on from that?
Move on.
Go ahead, sir.
So just to jump into this conversation, I'm Chris Bro from Umetrics. The ONC has labored mightily to bring the patient into the equation. So in the S&I framework, we have completed our implementation guide for Blue Button. And I believe, if I'm not mistaken, the ONC is encouraged HIEs to open up their data for patient access. So the HIE movement may be started in an era before the patient might have been as enabled as they are now, but progressively patients will have very sophisticated IT tools in their own hands that are secure, that can access the data. And I would propose that it's hard for a patient or their proxy to consent to anything if they don't know what's in the data. So in the spirit of opening the data, and I know that many HIEs are launching Blue Button programs, opening the data means letting the patient see what's there. And I would say, as we move forward, since there is now in the implementation guide, direct as a method of communicating securely with a patient, a federal standard, there are the means and a need to include the patient in the discussion about HIEs.
Any comments from the panel?
Amen.
Yeah.
So how about in Indiana? Is there a Blue Button in the HIE?
We did Blue Button long ago when it was Jim Semino's Blue Button. So we haven't done the new Blue Button, but here's where it gets complex. So again, you've painted a vision, haven't you? This is the ideal. This is what so everybody wants world peace, right? Why don't we have world peace today?
Because there's no implementation guide.
So, no, that's not true. So that's exactly, so since you said that, we spend so much time in this country on standards and implementation guides. The nice thing about standards, as I said earlier today, is there's so many of them. The nice thing about standards is it's like a toothbrush. Everybody's got one, you don't want anybody else's. It is not about implementation guides and standards. It is about the people behind this that prevents it from getting implemented.
I agree with that 100%.
So in our health information exchange, to be very clear, it is not the HIE's data. It is the individual participants' data. And so individual participants in our HIE say, if patients want their data, this Blue Button thing, no thanks. We'll go through our standard operating procedures where people call the HMIS phone number and get their data. And that's what they want to do today. Not because they don't think Blue Button is good, but because they have business processes, and that business process is probably number 217 in their business plan.
So under MU2, they have a positive obligation to allow a patient
if they want the money.
If they want the money.
Yes, but they have right. Thank you, kudos. In the spirit of doing the right thing, they have at least an ethical obligation to get on board with a national standard that many people agree with and that I think progressively patients will require. But it is an evolution. You're right.
It's interesting. You have Dr. Grannis there. He's very involved in the World Health Organization. Yeah, World Health Organization. So and of course, Linda is a meaningful use expert. So, any other comments?
I think it's interesting. We recently invited Ligia Riccardi to speak at Booz Allen, and she's with ONC and she does patient engagement. And she was talking about Blue Button Plus, and one of her comments is that until patients know enough to even ask or think to ask about their data and sharing their data, there's no compelling reason why a provider organization, because it involves cost and it causes complexity, will want to do it. So it's sort of a two-sided thing where patients have to start to know and understand and want to.
There's a compelling ethical reason as a physician who's practiced medicine, as I'm sure Sean would agree, to protect my patient. And part of protecting my patient is making sure that if I'm somehow not available or my system is down or something else, they're in another state, they have the basic minimum data to keep them safe. And I think not everyone in my profession would agree with that, but basically I think we all agree as a profession we want to do best by our patient. So I agree it's hard and it's new and it's evolving, but I maintain we should uphold the highest ethical standard of our profession and make this happen.
Question over there.
Scott Mace with Health Leaders Media. First a comment and then a question. The comment is, many providers and payers have signed something called the Blue Button Pledge, and this whole discussion makes me wonder what the value of that pledge is if in fact they're not actually doing anything other than pledging to support it sometime.
Well, Damon is actually participated in the Blue Button Pledge, right? So we got a great person.
Yeah, I used to be in our consumer e-health program. What was your question going to be? I used to work for Ligea.
Right. Well, that was my comment. The question goes back to the cloud. Linda, you mentioned Amazon, and I talk to providers all the time about putting their electronic personal health information in the cloud, and they are very, very nervous about using Amazon. They say it's a public cloud infrastructure. I've come across very little evidence that they're inclined to go anything other than private cloud, and I wondered, are you seeing something different than what I'm hearing from all these providers?
No. None of our clients are even interested in talking about public cloud, even though it's less expensive. When we're talking about patient information or research information, it's always, the discussion is always, we'll put it in the private cloud.
So I think you've answered your question about whether the analysis and the information will ever be in the same place, and it may be a while.
It may be a while. Well, we can bring the information into the private cloud, right? It's
Right.
just with permission and through data use agreements and to be able to move that data to that place.
Mm-hmm.
But there are a lot of startups who claim that they're putting all this big data on Amazon's cloud and doing wonderful things with it, but once you get into the question of patient-protected information, I don't think that's going to happen anytime soon.
No, I don't think you can do it without being, part of a, secure system, right? That includes a private cloud.
HIPAA support in Amazon cloud is not there. So thank you.
Thank you.
Hi, this is Rita Grewal from the Department of Veterans Affairs. Just need some clarification on the repository you mentioned. Now, where does the data actually reside? Does it reside with the healthcare organizations, or does it reside as another repository within the Health Information Exchange?
I think you're asking me.
Yes.
Yeah, so it resides, that second copy outside of the healthcare organization's copy resides at a data center maintained by the Health Information Exchange Service Organization. So there's a separate data center where that information is stored.
Okay, and also I heard a lot about everybody mentioning that, of course, there's no standardization of data. I didn't hear anybody mention the ICD-9 codes, or hopefully by next year we'll have ICD-10 implemented. So anybody using the ICD-10 data to standardize, the diagnoses or disease processes?
So we're seeing nobody use ICD-10, so this is completely editorialization. Okay. I'm wondering if the U.S. is going to skip ICD-10. You watch, see people push,
the way it's headed, it
and
might be.
we might skip 10 and go from 9 to 11. I'm not joking. I think that's a real possibility. Nobody in our information exchange is using 10 right now.
Okay, thank you.
Helen, did you have a question? Oh, come on. We have a couple minutes.
I just wanted to piggyback on that question. I wanted to ask Linda, since you brought up the cloud and Amazon. I haven't dealt with Amazon, but one of the things that I am dealing with the cloud vendors, and we talked about data centers and where do they reside and where is your data that they're outsourcing to South America, to other countries. I'm wondering what you're doing. I know what I'm doing in terms of contracts and negotiating contracts and provisions to make them accountable, but I'm just curious to get your perspective and how are you knowing where your data actually is going with those subcontractors?
Yeah, unfortunately, I'm not involved in the legal processes of negotiating our contracts, but my guess is that because of the way that we think about privacy and who our clients are, that we're pretty strict about that with our negotiations and in terms of where the data. And I certainly know that some of the federal clients are very specific about the fact that it needs to remain in the United States.
I've been told that we've run out of time, so let's thank the panelists.
Go on and on. We're going to move some chairs, and pretty soon we're going to have a fireside chat with Dr. Karen DeSalvo, and Sahid Shah is going to create a dialogue with her that we hope you'll enjoy. And so just give us a few minutes to get things rearranged.